Our next speaker is Dr. Blake, and she'll be talking about cost-effective management of syncope.
Thank you very much, and thanks for inviting me. And I've now realized that I get to really change my talk sort of on the fly, and I'm going to do that because we've had some very good presentations, particularly the last one, about some of the major causes of syncope. And so I have to admit that a good part of my job is done, and I get to do the fun stuff. So we're going to talk about cost-effective management of syncope. And the first thing that I would say conceptually about that is that absolutely the most critical thing is to start with the right diagnosis. And as you saw from the last speaker, the right diagnosis when you have patients with syncope is going to be vasovagal syncope almost 50% of the time. So step number one is figure out, does this patient have vasodepressor syncope? Use the history above all, and you've then taken care of 50% of the patients, and you really don't need to do any further testing. And on the recent electrophysiology boards, that was indeed one of the questions, where by history alone, it was that diagnosis, do no more, and collect $200 and pass go. So then the next part, in terms of, let me see if I can figure out how this works. Am I doing it right? No, I am not. But this right, there we go. So as I mentioned, another part of my talk has really been done for me, which is to define syncope. And as you saw, it's a syndrome, and I'm going to emphasize that the syndrome part more than anything else, because syndrome means is that there are multiple different causes, and that one of our big jobs is to figure out what those causes might be, and that in the research literature about syncope, one of the challenges is that it's really, and this is like your word crud, Doug, it's a gamish. And these populations of patients that are put into a given study will be people who have blacked out because of medications. It will be people who've blacked out because they're anemic. Somebody else has blacked out because they have vasovagal syncope, and the next person has blacked out because they have ventricular tachycardia. And so I think it's important to really evaluate the literature carefully, look at the study design, the methods, the patient population, because that's going to tell you how useful is that study for the patient that you might be seeing right in front of you. If we look at the burden of syncope, and you've seen some of this data, the main thing that I'd like to emphasize here is that the amount of healthcare expenditures is quite large, and with any study that you look at, there will be limitations in terms of the prediction of the cost associated with the evaluation. And why is that? It has to do with what data sets are available to the investigators. So for example, if someone looks at an inpatient hospital data set, that will be one population of patients, and around those charges that are used to calculate the cost are missing all the data about spells before or after, perhaps the outpatient diagnostic testing that may take place over a series of not just days but weeks to months, the physician charges, etc. But what we do know is that acute care, meaning typically emergency room or urgent care visits, rise exponentially for syncope as people get older. And so as the population is getting older, I think this is one of the challenges before us, is trying to get better and better at being able to put on the filters and be able to sort patients as quickly as we can into the high risk and the low risk categories. I'd also draw attention to the fact that the median length of stay, if someone is admitted to the hospital, is 3 days, and that's a lot of money. And then the other challenge that we have is, and it's from a regulatory standpoint, is that 50% of the people who are admitted to the hospital with a diagnosis of syncope, when they go home, their discharge diagnosis, primary diagnosis on their sheet that goes into Medicare or whoever, is still syncope. That is a problem because it means that 3 days were spent in the hospital, median, and no further, more specific diagnosis was arrived at in those 3 days. You still have a patient with an unanswered or unresolved question. And I think this also explains why, from the standpoint of the Medicare RAC auditors, that they have launched in some areas, in some Medicare regions, they've actually launched a prepayment 100% review of all cases that someone goes home and their diagnosis is syncope, because they've said, my gosh, we're spending all this money, people are spending all this time in the hospital, and we can only get a 50% yield, and their presumption is that the admission perhaps was inappropriate. So, as was alluded to, I think it's also important to think about whose cost and what kind of cost are we dealing with. So if you take a patient-centered approach, there are good studies that show that syncope is equivalent. Recurrent syncope for a patient is equivalent to having severely progressive rheumatoid arthritis, and if it remains undiagnosed and untreated, it is equivalent to having end-stage renal disease. So there is a significant impairment of quality of life. There is loss of wages depending on what somebody's professional life is like and whether they are able to continue to work. Certainly if they are a long-distance truck driver, they have lost their commercial license, for example. The cost of their medical care, the risk of injury, and then what we are most concerned about, I would say, is that we definitely want to catch, so to speak, and have a safety net for those people who are at risk of dying from it. Similarly, and again looking at what we now would say is a more patient and family-centric view, there is a considerable impairment on the quality of life for family members who have to assume the responsibilities, perhaps, of providing income to the household, doing all of the driving, and having considerable apprehension about leaving people home alone if when you come home they've blacked out and they've injured themselves. And then for clinicians, I think none of us like diagnostic uncertainty. We like to get closure, and we then like to be able to go on to establish a treatment. And then there's concern. We want to catch people so that bad things don't happen to them and that there's no risk, or as low a risk as possible, of medical liability issues. For facilities, it's an issue of cost of care and reimbursement. I think hospitals, those that are under the prepayment audits now, are going to be much more concerned when clinicians decide to admit somebody, because they want to be sure that they will be paid, and they will be paid if that admission was appropriate. For payers, meaning the businesses that employ people, it's obviously an issue of lost productivity and the cost of care. Same for insurance cost of care. And then for society in general, it's issues like safety and people driving, even if they've been instructed for a period of time that they shouldn't. So the other important point, I think, is to realize with the different studies that get done that the outcomes are going to vary depending on the perspective that you take. And I think most clinicians would say that they want us, or that we want to take the perspective of how long does it take us to get to a diagnosis, because once we get to the diagnosis, we're going to be able to then start to work our way through the various options for treatment. And I'm intentionally not focusing during this talk about treatment, because when you only get 20 minutes, or actually a little less than that, you get to pick and choose what you're going to talk about. And I've decided that I think we have to get to a diagnosis first. As was previously said, I think Doug referred to the quality-adjusted life years in terms of renal denervation. Certainly the data with respect to the comparison to rheumatoid arthritis tells us that that's a legitimate measure. And then I would say that as you go through diagnostic testing, think very hard at each step along the way of this concept of the net reclassification effect. And what that means is, based on where the patient and I are at this point in time, what is the likelihood that that patient will be reclassified by the next test that I plan to order? And if it is extremely low, then that should really give me pause. Whereas if I think that it is going to make a big difference, then I would go there next. Comparative effectiveness, I think, has been mentioned in some of the other talks. Dr. Al-Khatib talked about it with respect to the novel anticoagulants. We do suffer from the fact that most clinical trials are actually comparing what is called usual medical care to something new or a specific therapy, but being able to have in a syndrome a uniform enough population of patients to be able to then make real comparisons of the comparative effectiveness is sometimes difficult. I want to just remind people that there is the notion that the value of the healthcare that we deliver, whether it is with respect to the value to the patient, the value to the health system, is going to be quality divided by cost. And that correct diagnosis means, particularly I think for us, how quickly do we get to a diagnosis? How quickly do we sort patients between whether they have a benign or a malignant etiology? And then how quickly are we able to tease out those patients who may have multiple etiologies for syncope? Now, in reality, because I think we've all had patients who've had multiple etiologies, but in reality, they are few and far between. And at least in my clinical experience, their causes of syncope don't all show up at the same time, thank goodness. So I've had people who, the first time I see them, it's VT, post-MI VT, and then sometime later they have post-micturition syncope because they've gotten older and, you know, those sorts of things. And then down the road, they may develop partial complex seizures, but it's rare that there will be multiple etiologies going on at once. And then, as was mentioned earlier with Dr. Laccaretti, I think also in this area, as in others, this notion of as low as reasonably achievable applies here, in that we want to use the diagnostic tests that are going to give us the most net reclassification, the most value for our dollar, but also are at low risk to the patient, and the same is going to be true for the therapies that we select. There we go. Briefly, I'm going to talk just about how places you can go to look for information. So a variety of centers, a variety of populations and settings have tried to develop what you might call rules for risk stratification. So in San Francisco, in the emergency room, at UC San Francisco, they evaluated people with syncope or presyncope. They identified these various factors, and if a patient had any one of those factors, they were classified in a dichotomous mode to high risk, and they defined high risk as people who otherwise would be at risk for an adverse event such as dying, an MI, arrhythmia, pulmonary embolus, stroke, etc. If we look at another rule, this is the Rose rule. It's a little bit different. It does rely on laboratory studies a bit more, including the BNP, pre-hospital bradycardia. You can see there the acknowledgement of the fact that some syncope is caused by bleeding, some of it's caused by pulmonary emboli, myocardial infarction, those sorts of things. Sensitivity for that rule is 87%, specificity 57%. Let's see. Okay, Boston syncope rule, again, this one is more complicated and probably is better placed in a clinical decision support system in an electronic health. There are actually a total of 19 different factors that get added up to calculate a risk score with these folks, but you do get sensitivity of 97%, but specificity is still lagging. Going next in terms of thinking and summarizing about risk stratification scores, the tools are complex. I think they are going to be easier for us to use if they get embedded into our EHRs. Specificity of all of them is low. Everything depends on the population that's been studied and whether the interest was on the early adverse events, the life-threatening disorders, and for the late outcomes, which frequently are affected by comorbidities and by frailty. The approach in all of these investigations was if someone was designated as high risk, they then were monitored and had early evaluation to a syncope unit, observation unit, or they were admitted. Let's see, I think I'm going to go through a few of these. One of the things I'd like to think about conceptually is, and you'll see more and more of this, and you'll see it certainly as we really become more and more along the pathway of healthcare reform, there is enormous interest right now on the whole area of appropriate use of obviously hospitalization, but also outpatient diagnostic testing. Concern about overuse, the estimate is that perhaps 30% of healthcare costs could be avoided if we were more sort of cognizant of that and cautious in terms of our ordering, and that increasingly clinicians will be paid on what's called value-based purchasing models. And what that means is that you'll be paid at a premium, so to speak, if you deliver high-quality, low-cost care, and then at the bottom of the list will be those who are deemed to have delivered low-quality, low-cost, or excuse me, high-cost care, next to the bottom. The American College of Cardiology recognized the need for a change in language of how they describe particularly the use of either diagnostic tests or the use of particular therapies, saying now that they prefer a 3 sort of level appropriateness score, which would be appropriate care, may be appropriate care, whereas previously the word was uncertain, and rarely appropriate care, whereas previously the word was inappropriate. And this recognizes that there will always be exceptions to these rules. So those were changed in February. And then overuse has been described as provision of treatments that provide zero or negligible benefit to patients and potentially expose them to the risk of harm. So vasovagal syncope, I want to just refer people, and you can find this. Rob Sheldon, one of Vangelis's colleagues, published this in 2006. Really a just simple, beautiful score for sorting out who has vasovagal syncope and who doesn't, although please note that he did right from the get-go exclude people who had a cardiomyopathy or a previous myocardial infarction. And then syncope evaluation units, these can be inpatient or outpatient, but basically what they do, their purpose is to have people who are interested in evaluating syncope patients and having access to the resources that are needed. And there's evidence that there's a higher likelihood if somebody goes to one of these units that they will come out of that unit, that evaluation, with a diagnosis. And these don't necessarily need to be led by physicians. In fact, there are good examples to be found of specialist nurse-led protocol-driven units that are particularly good at sorting out the high and low-risk patients, developing diagnosis and management plans, and being able to reduce readmission to the hospital. And so in summary, I would say there are a number of risk stratification tools and scores that can be used. Please remember to sort out or decide right away whether someone has vasovagal syncope. Think about using Rob Sheldon's Calgary tool. Look at whether you can create or have access to what is the equivalent of a syncope monitoring unit. Always add to your physical examination such things as orthostatic vital signs, oximetry, carotid sinus massage. Monitoring should be used, I would say, sparingly, unless you do think that there's a high likelihood of an arrhythmia problem. Echocardiography, even though we think of it as simple because it's widely available, does cost a lot of money. Tilt table testing, I have to say, I used to do a lot of it. I'm now less enamored. And then access to subspecialty follow-up in selected patients. And that cost-effective does not necessarily mean low cost. That value really is quality over cost. So we don't want to compromise the quality of the care by not doing testing that is necessary. The greatest opportunity to be able to reduce what I would call the marginal costs is by reducing the admissions to the hospital and not performing diagnostic tests that are unlikely to result in a net reclassification effect. And that we certainly need much more prospective health services research if we're able to, as the population ages and more people have syncope, if we're going to be able to manage their care in the most cost-effective way. Thank you.